Hello everyone, I'm Sadaf Marashi-Pour, and in this presentation, I will talk about a report we have published at Bureau of Health Information on readmission and returns to acute care following hospitalization for 8 clinical conditions across New South Wales public hospitals during July 2015 to June 2018. Thanks to Dr. Diane Watson for her contribution to this work and the presentation. The Bureau of Health Information is a board-governed organization that provides the community healthcare professionals and policymakers with information that enhances transparency of the performance of healthcare system in New South Wales in order to inform actions to improve healthcare and strengthen accountability. We started reporting on readmission since 2015, using July 2009 to June 2012 data as the reference period, and this is BHI's third report on readmission. Hospital readmission is an important performance measure that can be used as an indicator in both clinical practice and health system management. It should be looked at alongside other measures and used as a screening tool to inform assessments of healthcare performance and highlight potential areas for improvement. BHI report on readmission provide community and healthcare professionals with information about the performance of more than 70 public hospitals for 8 clinical conditions. Extensive literature review and engagement with clinicians, managers, and policymakers helped the development of the report and exploring the results. You can find more details on the methods and the results and other report materials for this and previous readmission reports at Bureau of Health Information website. This slide shows the 8 clinical conditions included in our analysis and the report, which accounts for about 12% of acute emergency hospitalizations for people aged 15 years and older. In order to fairly report on hospitals, we use risk-standardised readmission ratio, which compares each hospital readmission with an average New South Wales hospital with the same case mix and is calculated as a ratio of the observed to the expected number of readmissions. Expected numbers calculated using condition-specific New South Wales level prediction models using fine and gray computing risk regression, taking into account patient-level risk factors outside the control of the hospitals and the computing risk of death. Results presented in funnel plots with 95% and 99.8% control limits based on Poisson distribution. We used linked admitted patient data collection, which includes all admissions, including electives and emergencies, and both public and private hospital data, and registry of birth, deaths, and marriages for these analyses. Using these data sources, we were able to follow patients' entire journey through public and private hospitals. Transfers are taken into account, and multiple acute contiguous hospitalizations are considered as a single acute period of care. We used July 2015 to June 2018 as the reference period, and the two previous 3-year periods for looking at trends and validity analysis of the prediction models. Separate cohorts are constructed for each clinical condition. In this slide, you can see the cohort inclusion and exclusion criteria for AMI as an example. Acute admissions with the principal diagnosis of AMI among patients aged 15 years and older that were discharged alive from a New South Wales public hospital during the study period were included. Some of the other exclusion criteria include discharges at own risk, which was around 1%, as the hospital didn't have the chance to complete treatment, and in-hospital deaths, which was around 5%. And 16% were discharged from a private hospital, taking into account transfers. For this report, BHI uses an internationally unique and valuable method for identifying readmissions, in which the readmission includes both readmission following hospital discharge and returns to acute care from non-acute inpatient settings, as both provide insights into the quality and effectiveness of transitions of care. This includes readmissions to the same or a different hospital, public and private, using linked data. To the best of our knowledge, the only other organization using this method for identifying readmission is CMS at US. As you can see in this slide, the proportion of readmissions following discharge returning to the same hospital varied for each condition, ranging from 43% for hip fracture surgery to 83% for COPD. The proportion of returns to acute care from a non-acute hospitalization ranged from 2% for COPD to 42% for hip fracture surgery. These results show that a considerable number of readmissions would have been missed if linked data was not used. Like all other decisions, attribution of the index admissions and outcomes to the hospitals is a decision that we take very carefully. I mentioned here a couple of our attribution decision rules. More details could be found in the technical documents at our website. Overall, and in case of patient transfers, index admissions and readmissions are attributed to the last public hospital that discharged the patient to a non-acute care setting, on the basis that it is the responsibility of that hospital to ensure that their patients are well enough to leave acute care. Although private hospital data were included for accurately following patients' entire journeys, outcome identifications, and attributions, but our results focused on index admissions discharged from a public hospitals. When there is an overnight acute rehospitalization following discharge and not meeting the criteria for readmissions and preceding the first readmission, no readmission is assigned to that hospitalization, as the readmission might have been caused due to the care received in that middle rehospitalization, and it wouldn't be fair to be attributed. Risk factors included in the development of the New South Wales condition-specific prediction models include age, sex, elixir, comorbidities, and dementia using a one-year look-back period. This slide shows factors included in the final prediction models for each of the clinical cohorts and the C statistics. We assess the prediction ability of the models using C statistics in data from current and previous financial years. The C statistics were consistent with other readmission measures found in the literature. Variables included in the model and the direction of associations were reviewed by clinicians. The stability of the coefficients in the current and previous financial years were also tested. In this slide, you could see MI as an example showing coefficients were reasonably stable. This slide and the next slide show New South Wales age, sex standardized readmission rates between 2009 and 2018 for the 8 clinical conditions, showing that the rates remained relatively stable for most of these conditions. Exploring reasons for readmissions showed the majority of the readmissions were for the same or related conditions or for the conditions that were potentially related to hospital care. This slide shows the funnel plot for AMI. Hospitals located above the upper 95% control limits are considered as having higher than expected readmissions, shown with red dots, and green dots show those with lower than expected readmissions. As you can see in this slide, across all 8 conditions, the majority of hospitals had readmission results within the expected range. Results showed 2 hospitals had higher than expected readmissions for 3 conditions, and 6 hospitals had higher than expected readmissions for 2 conditions. We also provide individual hospital profiles for more than 70 public hospitals, including demographic details of their patients, hospital case mix, and how it differs from the New South Wales patient population, time series results, and more. This slide shows the first page of one of hospital's profiles showing the hospital's outlier status during different 3-year periods as an example. We thank the New South Wales Ministry of Health for access to population health and hospital data and the New South Wales Centre for Health Record Linkage for linking the relevant datasets. We thank members of advisory committees as well as New South Wales Health staff for ongoing support in the development and refinement of methodology to measure and report on readmissions. We also acknowledge BHI's dedicated teams whose expertise made the readmission reports possible. Thank you for listening to this presentation. For further details, please refer to our website, and please feel free to contact me if you have any questions. Thank you again.